Hi, everybody. My name is Christine Bennett, and I am the Community Education Manager with the Epilepsy Foundation New England. I want to thank you guys so much for being here tonight and joining us. We have a lot of us tonight joining us on our Wednesday webinar series. We have a topic that is very important. Actually, it's very dear and near to my heart. My daughter, Delia, as much as you know, has epilepsy, and she also has autism. So this topic is not only important to me, but I know to all of you. And we have a wonderful speaker tonight that I'm very excited to introduce, Dr. John Gaitanis. He is a pediatric epileptologist with Hasbro Children's Hospital. He received his medical degree from the Geisel School of Medicine at Dartmouth and the Warren Alpert Medical School at Brown University. He completed his residency in pediatrics at Strong Memorial Hospital through the University of Rochester Medical School, as well as his residency in neurology at Boston Children's Hospital through Harvard Medical School. He also completed his fellowship in epilepsy and neurophysiology at Beth Israel Deaconess Medical Center through Harvard Medical School. His clinical research focuses on finding improved biomarkers and therapeutics for epilepsy. Thank you so much for being here, Dr. Gaitanis.
Thanks. It's great to be here. And I'll introduce a little of kind of how I came into this too, because obviously in neurology, we have one brain. And I think, there are epilepsy foundations, there are autism foundations, but there are about a third of kids with epilepsy also have autism. About a third of kids with autism have epilepsy. So it kind of works in both directions. And in truth, these shouldn't be separate. Like we should be BFFs here. We should really work together, collaborate together, because it is one brain and it's one person. And sometimes that brain, unfortunately, does kind of express both situations together. And the reason I present this too is that there are some key differences in how we approach epilepsy. I think it's really important for the clinician not to think just in a vacuum of one issue. I think we have to really think of the whole child. This gets a little bit more into autism in general, because one of the things that's always been challenging in autism is that for many kids, it really is like a whole body condition. It's not purely a brain condition. So in medicine, we like to think in little compartmentalized ways, that this is just my issue and I don't have to think outside of these strict boundaries. But in reality, like you have many kids for example, who have autism, who have a lot of GI issues, GI inflammation, GI pain. They might have a lot of allergy symptoms. And so there could be immunologic differences. There could be GI differences. You can have also neurological differences like epilepsy, and it's one person. So we always have to think of everything together. I think it's really important to think of the whole person. And that's really the main focus here. And I'd like to make it interactive. I'll share the slides. I'd like to make it as interactive as possible. And again, I present this because I really think there are significant differences in how we should approach epilepsy within the autism population. Much of what I'm going to present is geared to the older kid with autism, or the young adult even. And so I'm going to talk a little bit about some of the issues in autism. I'm going to include things like self-injury, aggression, and then I'm going to talk a little specifically about autism and epilepsy, and then how these things are all linked up together. Again, this is a little more geared towards the young adult or older kid. So some of you may have interest in the younger child. The differences are significant enough that it's sort of a separate talk in a way, and I'm happy to do that too. But just to go through some of the definitions. So when we talk about seizures, we're talking about these clinical events that result from an abnormal firing of neurons. But when we talk about epilepsy, what we're describing are these recurrent unprovoked seizures. So that's the way we're describing it. And epilepsy, of course, is a condition that you see at the extremes of life in greatest frequency. Very common in pediatrics, but also very common in the elderly. In the elderly, though, it's mostly because of stroke. So it tends to be largely due to that. Whereas in kids, it's much more diverse in terms of the causes. So I'll give you an example of like what I would say is a pretty common scenario that I'd see. And now already I'm starting at 18, but this is actually the age of the child I'm seeing. And I'll say child often because even when they're like 27, they're still your kids, but they're technically adults. But so 18, so you're on the cusp of adulthood. And I think this is an important age because many times you're falling into this kind of rabbit hole of pediatrics doesn't want you, adult medicine doesn't want you. And this is a real challenge. Kids at this age do present a lot of challenge trying to find cure because it's like everybody is sort of like, oh, well, we don't see 18 or we, and you're hearing that from both sides of the equation. And that's another challenge in medicine. Like I mentioned that it's a whole person and we have to think about the brain and body together. There's also nothing magical about the age of 18. We really do have to think about working together with whoever's the best person to see that patient. So I kind of had that there intentionally, but this is a kid who really everything was fine at birth, and in the first year of life, things are going pretty well. Walking was a bit late. It was a little closer to 18 months, but really was doing okay otherwise, starting to use single words at a year. By 24 months was actually using two-word phrases. So things were developmentally just a little bit delayed with some of the motor skills, but otherwise language was really going well. It was very social. But what was happening to this child is around 20 to 24 months, had lots and lots of infectious illnesses, lots of antibiotic courses. And it was around 2 years when there was a developmental regression. And so for this child, what that regression looked like, it was complete loss of words, complete loss of babbling, very major change in behavior, crying all day, irritable, head banging, had to be driven in the car for long car rides just to kind of keep him calm and quiet. So major sensory issues. And there was a social reduction as well with that, just was not as interactive as was before. It was so severe that the car rides were almost hours of car time just to keep the child quiet. And then it was like this tricky dance the parents would have to do to get him from the car seat to bed to the crib without waking him. And because if they woke him, you'd have to kind of be back in the car all over again. And there's often a delay for that autism diagnosis, but by 28 months, finally that autism diagnosis came about. And at that stage, it was a real difference from 24 months. So not using words, not babbling. ABA started, and then goes from early intervention and home ABA to preschool with an ABA classroom. And there's some slow progress, but it's very slow in developing. So some single words, but lots of labeling, lots of prompting required. Continues on in ABA classes through the elementary into middle school, and continues to make slow, steady progress. Even starts to read, but has more kind of labeling and a little challenging with comprehension still. Still needs some prompting for I want sentences. And 12 is around when things get a little crazy. So that's why I kind of warn people who have younger kids with autism. This is not everybody. Okay, so I like to say this is one child. Doesn't mean that this would necessarily be any other individual's situation, but unfortunately, there are a lot of kids who go through a significant behavioral change and neurological change around puberty. And that's why I present this. And this is actually a fairly common occurrence. So I don't want to scare parents of younger kids. On the other hand, I don't want to dismiss what many of the parents of older kids have experienced, because it's a very important thing to consider. So at age 12, that's when the first seizure happened. And first seizure, very scary, 8-minute long, generalized tonic-clonic. All the studies were normal. MRI was normal. EEG was normal. So the decision was made not to start an anti-seizure med. But then a month later, a second seizure occurred. And that's when the child was started on levetiracetam, which caused major behavioral problems, which is a really common side effect of that, later changed to valproate. So the other thing that happened around that same time was that after that seizure occurred, there was also a behavioral change. Much worse, a major worsening in OCD behaviors, more self-injury, head strikes. So striking the temple, but also biting the wrist. And occasionally was lashing out against caregivers too. So you can imagine this is quite a difficult situation. This is a different child, but this gives you an example of what the result of the head injury was like. So often striking with using the palm and just kind of striking repeatedly at the eye or the temple, and leading to self-injury. And following that, there was a pretty major challenge we were seeing with self-injury, OCD, often coming on without a trigger. Sometimes there's always questions of what was bringing it out, and you can do a functional behavioral assessment for kids who experience this, but it's not always clear what leads up to each event. So sometimes we have to question, like maybe there are things like headaches or migraines that we don't realize. And when this was occurring, very difficult to console him. And because this is happening at puberty, this is also like a physically larger, getting to be a stronger and more muscular boy as well. So starting to outgrow the teachers and the staff with him. And what was an interesting pattern, which is something that we've seen with a lot of the kids, is that when the head injury and when self-injury and the aggression and the OCD was really, really bad, that's kind of when a seizure would happen. Accompanying that sometimes too with the aggression and self-injury, sometimes there was a lot of sleeplessness leading up to that. So you might go through a couple of sleepless nights, a lot of OCD, a lot of self-injury, and then a seizure would happen. After the seizure, the child's a lot calmer for a period of a few days. And this is when it gets, this is the saddest part of it, is like then, and I've had parents mention this to me, that nobody's ever relieved that there's a seizure, but they're almost relieved because they knew that they would have a few good days following the seizure. Like that's how bad the injury is. And so I kind of raised this as sort of a question of a second regression, because again, this was a child who had a developmental regression, in that around 24 months, made some slow, steady progress, but then sometime around adolescence or pre-adolescence, there was another regression that involved self-injury, aggressive behaviors, and then seizures. And that has major impact in every aspect of the child's life. I could pause for a second if anyone has questions about that case, because I bring that as a representative case. I don't bring it up to scare anyone or concern anybody about that possibility, but I just mention it because it is unfortunately a very common situation. If anyone has thoughts, but that's okay. I'll go on to, and I'm happy to entertain any questions at the end too. But a word on the autism and epilepsy. So, I mentioned at the beginning, a third of kids who have epilepsy can have autism, and a third of kids with autism can have epilepsy. It works in both directions. Obviously, you don't see this in adults with epilepsy, but in young kids. So you kind of have two peaks where you might see the epilepsy. You have some kids who developed epilepsy in infancy, and a good example of that would be some of the kids who have infantile spasms, or kids who have Dravet syndrome will develop epilepsy usually in infancy, and then later, much later, maybe get diagnosed with autism. We have to be careful with kids who present with early epilepsy, because many times the autism diagnosis was delayed for years because we were so focused on the seizures, and the seizures were so bad that there wasn't space to think about anything else. And then so like a child who could have been diagnosed with autism and maybe started therapy, at 2 or 3, might not have been diagnosed till 6 or 7 sometimes. We also have kids who develop epilepsy late though. And some of those kids might have either something like a benign focal epilepsy of childhood, or they can have things like absence seizures or myoclonic seizures. So both focal or generalized seizures can present much later. And that's the child I'm presenting. And we have to think about, when it comes to autism and epilepsy, we do have to think about the fact that there are some kids who have what we would call sleep-activated spike waves on their EEG, and how that might impact development. So again, it's really the seizures and the development. We have to think of them as like one and the same. And for kids who experience a major increase in spike waves during sleep, it's a reasonable question. How does this impact their development? And this would be an example of how in this child, when they're awake, they have occasional spike waves, but when they're asleep, they really increase to the point where it's like most of the study. So this is what a spike wave looks like. Each spike wave, this is a second here, from here to here is 1 second. And a spike wave is this really sharp deflection that looks like a spike. You can see this spike here and the spike here. And that's just really like a 1/5 of a second or 1/10 of a second. You wouldn't feel an individual spike, but when you have so many occupying 90% of the rate tracing, this may not actually cause a seizure, but the concern is like maybe it's interfering with sleep patterns and maybe it's affecting development. And we often call that Landau-Kleffner syndrome when you have a really high spike frequency, especially when it affects language. We might use the term Landau-Kleffner syndrome. And some of these kids that had a language regression. And then there's also the term called continuous spike wave during sleep, during slow wave sleep, which can have a more global effect on development. It's interesting though that, because I'm presenting a kid who had a regression around age 2, So most kids who have autism, so ASD/R, that's autism with regression. Most kids who have autism with regression usually see that around 2, but in Landau-Kleffner, it's usually after 3 years that you'd see the regression. And we sometimes will use a term called childhood disintegrative disorder. These are kids who have sort of a autism-like regression after age 3, and about 70% of those kids will have epilepsy. Very high percentage will have epilepsy. So there's obviously an interrelationship there. So we have to think about how does the epilepsy affect development is really important. How do the seizure medications affect development? How do those spike waves on EEG affect development? All those things are really important. That's why, again, it's one child, one brain. We have to think of this as a whole person. And so, I think a really important question here is, if you have both autism and epilepsy, can I approach this as just, I'm going to see you for the epilepsy and that's it, and I could treat you just like every other patient? Or do I have to actually think of you as kind of an individual and really consider how all these issues integrate together, and maybe the treatment and the approach should be different? And so obviously it's the second choice, because otherwise I wouldn't present it like that if there was no difference, and then we wouldn't really need this talk. But there really is a difference, and I think the neurologist has to be aware of that. And the group I'm in now at Brown has looked at some of the differences between patients with autism and epilepsy versus patients just with epilepsy. And there are a few differences that show up. Slightly more generalized seizures in kids who have autism and epilepsy than kids with just epilepsy. You tend to see more generalized tonic-clonic seizures in kids with autism and epilepsy. But the other thing that's really important, though, is like MRI rates are, it's in patients with autism and epilepsy, about 80% will have a normal MRI, where you're closer to 60% if you have epilepsy only. So it's the child I presented had a normal MRI. That's much more common to see that in patients with autism and epilepsy, particularly for the kids like this patient who had regression and had later onset epilepsy. Much more common that it's a normal study. I see the same thing in EEG, by the way, but we didn't report that here. But sometimes the medications that we use are different as well. So we have to think about what some of the side effects might be like, and what might be effective. For example, in patients with epilepsy only, levetiracetam tends to be used more than it is in patients with autism and epilepsy. Not a huge difference, but just like the patient I presented, I mean, levetiracetam is well known to cause sometimes behavioral side effects, and particularly aggression and agitation. And for a patient who already has challenges with aggression, that's not a good choice. Certain medications like topiramate is used a little more in patients with autism and epilepsy. And one reason is that many kids, unfortunately, like a lot of kids, are also on an atypical antipsychotic for behavior. And those can really result in obesity and significant weight gain and type 2 diabetes. Topiramate tends to lower appetite, so that actually can counteract that, as does zonisamide. So you kind of see a little bit higher rates of use there. Clobazam, too, is sometimes used a little more because it's a benzodiazepine and tends to be a little more calming. And so that's something important to recognize. There are some other things that are interesting, too. So this is another study I was part of, and it just looked at some of the unique features of patients with autism and epilepsy. But one thing I thought that was interesting, of all the different therapies, I mean, this is from parent surveys, but all the different medications that families would rate in terms of efficacy, the thing that actually turned out to be the highest in terms of efficacy based on parent reporting was ketogenic diet, which I think would include like low glycemic, modified Atkins. And what is interesting, there's not a lot of data for low glycemic diets for autism alone, but low glycemic diets, part of why they work for epilepsy, they reduce inflammation, they improve mitochondrial functioning. They're not sedating, too, so they don't have a negative impact on development. And so you have a lot of possible advantages, and they tend to lower appetite and reduce weight. So because a lot of kids are on antipsychotics and have gained a lot of weight, it actually has a lot of potential benefit. The challenge is, though, if you have a kid who has a really limited diet and really only eats chicken nuggets or pizza, then this is going to be a major heavy lift. But so I don't say that lightly, but it is worth noting that that's really high very high on the list. Of the seizure meds, primidone we don't use a lot, but valproic acid or Depakote was very high in terms of parent rating scales. Interestingly, Keppra was pretty high too, because it is a pretty effective med. So only about 15 or 20% of kids have aggression on it. And so for those who don't, I think they rate it highly. For those who do have aggression, they're off of it usually pretty quickly. And then there was some look at as well at supplements. So things like GABA, pyridoxine, vitamin B6, magnesium. The overall efficacy seems a little better with seizure meds, with ketogenic diet, but still, like parents reported some efficacy with some of those supplements, as well as things like hyperbaric oxygen as well. So it's kind of interesting. That raises some question about whether there might be some alternative treatment pathways that might be of value. The other question that comes up here is like, so this child I presented had both epilepsy and aggression, and they came around the same time. And I think, and it was a child who had a prior regression when he was younger. And does this all fit together, or are these separate things? And this is something too that I went back and looked at in my own patients. And one of the things we noticed in the kids who had regression, developmental regression in epilepsy, the epilepsy for kids who had a history of regression in autism, about half of those kids had epilepsy. For the kids without regression, it was a lower percentage. It was like just under 40%. For the kids who had regression, a much higher percentage also had aggression, not to confuse that with regression. But so almost 75% of kids who had regression were exhibiting aggressive or self-injurious behaviors, compared to just over 50% who did not have regression. And if you look at the kids who had epilepsy and aggression, overall, that's about a third of kids who had a regression who, or I'm sorry, it was about, if you look at all three together, it's about 44% of kids who had regression who experienced all three, as opposed to about 20% who did not have regression. So it's like it clearly, like the epilepsy and aggression and self-injury were much higher in prevalence than kids who did not have a regression. Does that make sense? So I think what I take from that is for kids who experience a developmental regression, we have to think of them a little bit differently, and we have to think about ways to prevent these kind of outcomes early, because what we can do to really prevent from going down this path. And we have to think too differently about the mechanisms, because this is not like a run-of-the-mill child presenting with epilepsy. This is really a unique and very different story. And so some things were not substantially different, like things like sleep disturbance, for example, actually you see in both populations, whether you had regression or not. And that tends to be just common in general in patients with autism, but very important to monitor sleep. And one reason I would say to pay a lot of attention to sleep is that for many of the kids I see who have autism and epilepsy, sometimes the seizure happens after they haven't slept for 1 or 2 nights. And so if the sleep is disrupted, then seizure might be imminent and might be happening within the next day or two. I think this would be a place where if kids can wear like a Fitbit or a wearable, there might be value of tracking sleep data and then seeing if you go through a few nights of bad sleep, that's when you might need to be more on guard. It might also give you the ability to think about what could we do about seizure meds when you go through that. Like maybe that's a time to raise meds or get ahead of that. So again, differences. I wouldn't do that, and I wouldn't think of that in a neurotypical patient with epilepsy, but certainly would consider that in a child with autism and epilepsy. And so I kind of term this second regression. Like this is not a term in the medical literature. This is just my own term, but I think of this as like a second regression. I think a lot of the kids have gone through, and this is not a trivial thing, because already the family has really been traumatized by that first regression, because they had a child who was developing well, and then something was lost, and it's incredibly sad to experience that. But then to go through it again is just traumatizing, and it affects. And now this is a school age child too, so now you have therapists and teachers and everybody else involved in this child's life, and you're experiencing suddenly aggressive behavior, self-injury, and epilepsy all together. That is like way too much. There's like the saying, my least favorite saying is when people say God only gives you what you can handle. That's really an unfair saying to people, because this is more than anybody can handle. This is like, I don't know who invented that saying, but they need to live with some of these issues, I think, and realize that nobody gave this to anybody. This is just a really difficult situation. and it's reasonably more than anybody can handle. It's hard for everybody involved. And so, but this is something I see quite often, and we have to think about it a little differently than, again, very different than just run-of-the-mill epilepsy. We have to think about root causes. I mean, there can be quite a few things at play. Like we have to think about things like neurotransmitter disorders. That might be one possible pathway. Here I'm showing the mGluR3. That's a glutamate receptor. Glutamate's the excitatory neurotransmitter, and that would be an example where Fragile X is an example that where that glutamate receptor has an abnormality. We could think about things that regulate growth. So this is actually showing the mTOR molecule, which is a growth regulator. And that's really important for things like tuberous sclerosis, neurofibromatosis, but also for it's maybe an underlying factor for epilepsy in general, because growth pathways do have a lot to do with epilepsy generation within the brain. We could think about electrolyte channels for like sodium, potassium, chloride. So sometimes if there's an aberration of those channels, that could also be an issue. In particular, the sodium channel, so SCN is a sodium channel, but SCN1A is the channel that's important for Dravet syndrome. And those kids characteristically have epilepsy. We have to think about metabolic things. And the mitochondria are the powerhouses, the energy producers of the cell. And so this is an interesting possibility because many of the kids who experienced regression did so in the setting of like infectious illnesses, frequent infections, a lot of antibiotic use. So it kind of raises a question. Maybe there was trouble with energy metabolism. And we have to think about immunologic things too. That kind of ties in as well with the infection. But this slide's just showing NMDA receptor antibodies. So if you have antibodies that attach to a neurotransmitter, that could really be very disruptive to the brain. I don't present these to make life difficult to think of all these things, but obviously no one individual has all those things, but it just means the neurologist has to think about all these possibilities, right? This is not my run-of-the-mill epilepsy patient. I have to think about what's behind this because each of those things might lead to different treatment pathways. And in particular, too, I think it's important to think about how does inflammation and epilepsy come together? Because when you have inflammation, it does tend to lead, inflammation and epilepsy do really go together in many, many conditions. Sometimes brain malformations have evidence of inflammation, but some of the kids I see with autism and epilepsy actually do experience these cycles of worsening behavior and epilepsy occurring, sometimes in the setting of post-illness, like febrile illnesses or even post-infectious symptoms. So it's a lot to consider, but that burden should be for the neurologist, right? And that should be something that's where our challenge is to think of each kid individually. What makes that kid tick, and how am I going to identify? Is there a metabolic issue? Is there an immunologic issue? But that burden is for me to solve, not for the parent. I mean, it shouldn't have to be for the parents. Although honestly, if I didn't have some really amazing parents directing me in the right place, I probably would have missed a lot of diagnoses along the way. So I welcome that, but that should be my burden to think of. You have enough to worry about, so we don't need to add that burden to people's plates. But again, think of the whole patient, right? We have to think of the whole patient, and we have to think of this is one child, one brain. And if there are other issues like GI issues, I have kids, for example, who have Crohn's disease, inflammatory bowel disease, who have autism and Crohn's disease, and it should not come as a surprise that their seizures happen when their bowel symptoms are flaring up. Would I treat that patient just like anybody with epilepsy, or do I have to think of them really as a kid who has an inflammatory condition that's contributing to their seizures, right? So it makes sense that it would be the latter.
I was muted.
Right. Just getting back to when we choose a seizure med, though, we really have to think of everything, but it really comes down to trying to improve quality of life, safety and quality of life. And so normally we think about treating normally we would not treat a first seizure because only a minority of patients are going to have a second seizure if they've had one. But I bring this up because in autism and epilepsy, I think the rates are very different. So in the child I presented, he wasn't treated with the first seizure, but he had something unique in his history. He did have autism. He had regression. And I think his rate of having a second seizure, having epilepsy was much higher. And I think we have to really question that decision to wait until that second seizure. I'm going to go through some of this is more general epilepsy, but I think it's just worth noting, and I always come back to this in every epilepsy talk, that unfortunately our meds are not perfect. And for patients who have epilepsy, there still are about a third of patients who we try multiple meds and we still can't fully control their seizures. And I think this is actually something that I've noticed is a challenge in a lot of the patients I see with autism and epilepsy because they go through these cycles. They're not sleeping, they have the behavioral change. Sometimes it's like a post-infectious or inflammatory thing that's triggering them. And in some of the young women I see, they also can have perimenstrual seizures. So all these things make us consider non-traditional treatment pathways. Like, for example, perimenstrual seizures, I have to consider whether I use progesterone. That's not a standard seizure med, but progesterone is calming to the brain and can actually help sometimes for both behavior regulation as well as perimenstrual seizures. And somebody who has a lot of challenge with sleep, for example, or I might have to really think of how I get ahead of the sleep issue. Maybe I could prevent the seizure that way. Or in kids who experience like increased OCD or aggression and then don't sleep and then have a seizure, maybe I don't need to put them on the same dose of seizure medicine every day evenly. Maybe I need to adjust their dose when the symptoms are getting worse. So again, different treatment pathways that we consider.
Right now again.
And as I mentioned before, a ketogenic diet is actually rated pretty highly by parents. So I wouldn't dismiss that. It's just that a lot of kids have significant feeding challenges. But I think even for autism alone, for many kids, ketogenic diet might serve some benefit. There are some literature to support that. So there have been some trials of keto or low glycemic diet in autism.
Okay,
And the trends are towards improved behavioral regulation and improving some of the core symptoms in autism.
I'll call you when it's over.
Okay. One thing that's a little different, though, is some of the trials that have been used for keto diet in autism have used a gluten and casein-free diet, and they've been a little higher in MCT oil. And that's different from what we do in epilepsy. In epilepsy, we don't go gluten, casein-free, and keto, but there may be more value to doing that in patients with autism. Vagus nerve stimulation, too, might have a unique role in autism and epilepsy because when we think about aggression is a total adrenaline type response. And so when you get that surge of adrenaline, the thing that calms it is the vagus nerve. So the vagus nerve is your best friend. For kids who experience autism and aggression, we need to get that vagus nerve active. And I have seen some kids who have shown behavioral improvement with vagus nerve stimulation as well as improvement in epilepsy. And the other thing that's interesting is with the vagus nerve stimulator, you can activate it when you need to. So you have the option as a parent to actually activate it for aggression as well as for seizures. You could consider doing it that way. But so it might be valuable on both accounts, but it does require surgery. And then the really interesting thing with epilepsy surgery is that for a very select subpopulation of kids, sometimes surgery helps development. And so now I wouldn't jump to this normally, right? But I just had a patient recently who underwent epilepsy surgery who also has autism. And here's the difference is that for the patients who do well with this, they generally have a developmental brain malformation. So they have one area of the brain that never developed as it should have. And that results in both the developmental concerns, but it also is causing their seizures. So imagine if you have an area of the brain that does nothing useful, and all it does is it causes problems by generating seizures and spike waves all the time. So if you identify a child like that, and that area, let's say that area is not near any essential function, in that situation, taking that area out, it's like taking the bad apple out. I have some kids who showed improvement in language and overall improvement in development from having undergone surgery. So I don't want to ever dismiss that in the right child, but this is not, the patient I'm presenting here had a normal brain MRI. This would not be the right option for that child. But it can be an option for kids who have a developmental brain abnormality. This is my least favorite thing to discuss, but I just add it here because unfortunately, CEDAP is the biggest fear everybody has. And a lot of the kids I'm seeing with autism are later when they develop epilepsy, and some of them do have sleep onset seizures, and it creates a real problem for, for how do you monitor that? How do you safely, as a parent, how do you safely just go to bed at night and feel comfortable? And And so important to discuss, but the reason I bring this up is the rates of SUDEP are higher in young adults. And a lot of the kids I see are no longer kids. A lot of them are young adults. Um, and you can see it in a variety of epilepsies, but usually people with more severe epilepsy. But the nighttime is a big challenge in how to monitor safely. So for some of the young adults I see, we have to consider monitoring systems that would be effective. So for some people, so for example, there is some evidence that having a dog is a useful monitoring system. It doesn't always have to be a specific epilepsy dog. Sometimes just the family pet can be valuable. But there are some devices too that are worth noting, like the SAMI, SAMI camera is a device that would monitor seizures using a camera, and then it can alert the parent using Bluetooth to your phone. So it's an alerting device if it feels like it's detecting a seizure. And then you have watches as well, like the Embrace by Empatica. You have Seizure Alarm, which is an app for Apple Watch or for Android devices. And those are examples of wearable seizure monitors. In patients with autism, many of them have sensor integration issues, so they're not going to wear a watch like that. So the SAMI camera might be a good option. And for some patients with autism, having a dog could actually be beneficial from a behavioral standpoint, as well as for the epilepsy. So I'm not, by any means, I don't want people to run out and get a dog if it doesn't fit with your life. It has to really fit with your life and your family, obviously, because that's a major investment to take on. But I think there can be some value there. And it is worth noting, it is thankfully a very rare concern, but we have to consider ways to reduce the risk. All the things I mentioned. I'll just go through real quick, like all the monitors I mentioned, but you have a host of different ones. And I forgot to mention, just as low tech as a sound monitor can be of value. This is an example of the SAMI camera, the Empatica watch. I'll skip the electrodermal activity, but this is Seizure Alarm, which is another app. And I'd be happy to provide those. There's another watch called Inspire, which I don't use as much. Epicure, yet another watch. And I've had a few patients who've actually used a pulse oximeter as well. And that I'm only going to do if they have shown, usually if they've shown that they clearly do drop their SAT or raise their heart rate. There's even a mattress pad that detects this MFIT, would detect movement that would be suggestive of seizure. So you have a lot of devices, and then the dog, of course. But I'd say of all those, I would say probably the SAMI is the most common I've used in patients with autism because of the fact that they have sensor integration issues that prevent wearables. And I sometimes forget to mention that there are these things called anti-suffocation pillows. They're really cheap. I mean, you go on Amazon, buy one for $30. You could breathe through them because they have holes through them. So there's low resistance. So we always fear that somebody rolls on their stomach and is suffocated by the pillow. That would really prevent that. Because positioning is important because kids who are stomach sleepers are higher risk. And I think I'll just mention too, the seizure action plan is a really important thing to have. We have multiple seizure action plans that you can find on various different websites. But if you have an adult patient, and even if they're not in school, consider making a seizure action plan anyway, because it's better to consider what to do in the event of a seizure when you don't need, when there's not an urgency. It's better to do that when things are nice and calm, just so that you don't have to think about it when an emergency strikes. And I hate to end on that note, but I kind of had to mention that because I just always want to throw that safety bit in. And so I know the talk was more on autism and epilepsy, but when I deal with young adults, we have a different issue because they're no longer sleeping with their parents. Sometimes they're living separately too. And how to monitor and how to keep these young adults safe is a really big issue in a lot of people's minds. And so I can't, I feel like I can't ignore that topic, as difficult as that is. So that's a lot, but I'm open to any question. No, that was a lot to digest.
Hi, Dr. Gaitanis. We do have some questions in the chat that I'm going to go ahead and just kind of read for you.
Sure.
We have one question that says, I have a child recently diagnosed with epilepsy, level 3 autistic diagnosis, 18 months. She is 7. Is this very common? We suspected she was having absent seizures for years since age 2, but were dismissed as just stims.
That's a really common clinical challenge is what's a stim and what's an epsilon seizure. They can trick you either way, and it's probably more common that we do an EG and it turns out just to be a stim. But I would rather do the study than not do the study because I can't always tell clinically, and it really would change your treatment plan if it turns out to be seizure. Really, we need that's the kind of information we really do need to know. And then it raises secondary questions like, well, then if there are seizures during the day, maybe we need to do an EEG during the evening to make sure sleep is not more active than we realize, or maybe we need to think about monitoring differently for seizures. So it's a really common reason to misdiagnosis, unfortunately.
Sorry about that, Dr. Gaitanis. I believe I just accidentally muted you. I was
Oh,
I'm
yeah.
trying to unmute myself and I hit you by mistake, so I apologize.
No,
Um,
that was totally appropriate because I was going to make a real quick mention of the nonverbal patient because, for patients who are nonverbal, they're not going to describe to you the symptoms. So it really is incumbent on the caregiver to do so. I'm a big proponent of maternal instinct here. I think mothers here clearly have a very strong connection and know when something's wrong. And I think the clinicians should listen to that. It's because it's usually going to lead you the right direction. Um, Unfortunately, not everybody does listen to that, but they should because that's when you have a patient who's nonverbal, the parent and often the mother is their voice, and so it really is incumbent on us to pay attention to that.
Thank you so much, Dr. Gaitanis. There's a couple more questions. What questions can parents ask the neurologist to ensure they're considering the pieces you mentioned?
Yeah, I think yeah. So a lot of it comes down to it's always important to think of think about your child's trajectory and your history, and think about all the different pieces that have come up in their lives. So, for example, I mentioned the GI issues. A lot of kids I see have like EOE, which is an esophagitis. So it's an eosinophilic infiltration of the esophagus. A lot of kids I see do have GI pain or GI inflammation. I think that's an important thing to acknowledge. If you identify like sleep disturbance in relation to seizure, or if you identify behavioral disturbance, I think that's really important for the neurologist to be aware of. They may not ask that question, and a lot of people don't ask for young women. A lot of neurologists forget to ask about the menstrual cycle. So it's really important to pay attention to that because that may be a trigger for both behavior and seizures. And yet that question, is forgotten to be mentioned. And so I think all those little details add up, and I think sometimes the neurologist doesn't want to get into them because maybe they're not technically neurological, but they could actually be the answer as to how to control the seizures. So I really do think all those things we have to listen to and then follow your gut. So I think as a parent, if your gut is telling you something is not right or there's some more to the story, I would, just stay on that. Don't dismiss it because you're generally right on that. And so don't be afraid to ask that. Don't be afraid to let the neurologist know that you're not quite settled. That you want to pursue more answers.
Is there a reason why girls often get diagnosed later compared to boys?
For autism, yeah. So sometimes the presentation is a little bit different in girls. So some girls are sometimes language is not as much of a concern. This is not true for everyone, obviously, because I certainly have many girls who are non-speakers or unreliable speakers. But there are a lot of girls who are on the autism spectrum whose language skills were a little more advanced than the average boy in the autism spectrum. And so because language impairment wasn't as severe, that sometimes delays diagnosis. So the actual presentation looks different. Girls are generally, for most things, girls are a little more healthy in a sense. So girls do better in a lot of contexts. So like rates of autism are less in girls than they are in boys. We don't really understand why that is. If you have kids that have been like that were born prematurely, the girls usually do better than the boys. And on the other end of life, women tend to live longer than men. So there's something about being a girl that is a little bit protective. And I think that might account for the lower rates of autism in girls and also the milder presentations in a lot of girls. But what it is that leads to that difference, we actually don't know. So that's kind of surprising because it's such a basic thing, and yet we don't have a scientific answer for exactly what makes girls more resistant to autism.
We have actually multiple questions in the chat. I'm actually going to ask those. I'm going to go ahead and read this last one, Aristo Wong. After that, I believe we have Kelly, Kate, and Molly. We have quite a lot of questions. I don't mind people raising their hand and actually unmuting themselves and asking it themselves if they're more comfortable that way. If not, I am more than happy to continue to read these questions. So please, whatever anybody is most comfortable with, I'm happy with that as well. The next question was, for parents with young children that have already been diagnosed with epilepsy, but not autism, my daughter is 2 and has Dravet syndrome. Do we know the mechanisms that cause regression in autism? Is it solely due to poor seizure control? And what can we do to improve outcomes?
Yeah, I mean, that's a really important question. So in Dravet syndrome, developmental delays in autism are more common. So I hate to have to acknowledge that, but that is something we have to monitor. Development's really important. And in Dravet, because the seizures are at the forefront of the family's day-to-day life, the developmental issues sometimes take a back seat. And so the medical acknowledgement of that is often delayed. So I think starting with developmental assessment earlier is really important to do those assessments. Maybe make that developmental pediatric visit earlier. Do an ADOS test, which is the screening for autism. Like, go ahead and ask for that you can ask for that at 2 or 3. It's okay to do those assessments earlier, just to see where those numbers are, and then that gives you a baseline that you can kind of track over time. I do think the role of the mechanisms are complex because you have the seizures themselves, and not just for Dravet but for other conditions. I have some kids where unfortunately they've had really prolonged seizures or significant seizures, and after those seizures they've seen a developmental regression, and it's taken them a while to catch up. So the seizures themselves are one problem, but then the meds, of course, are a problem because we're using a lot of meds that are very sedating. And so I think it's really incumbent on the neurologist to think about, what can I do that's less sedating or has less of an impact on development? That's why I'm a big proponent of like ketogenic or low glycemic diet. And even things like vagus nerve stimulation, when appropriate, are nice because they're not sedating the child. And I have to, as much as something like clobazam can work for epilepsy, it can also be very sedating, right? So we have to just be careful about how much benzodiazepine we're using, or how we're using all these different meds in combination. So for a patient who's young, who's on 4 or 5 meds, there has to be a developmental effect just to the meds themselves. So the seizures are important, the meds are important, but I think sometimes there's a little more beyond that. Like, so I think we have to think about metabolism too. Like in Dravet, there may be some effect on mitochondrial functioning, for example. And I think about this with all patients, and especially in autism. Do we have to consider using vitamin cocktails that would benefit, that might benefit mitochondrial functioning, energy metabolism? Maybe that gives a little boost developmentally. There are some kids who might experience, like, for example, cerebral folate deficiency. Folate is vitamin B9. We don't test for that routinely because you have to do a lumbar puncture test. But giving like extra B vitamins is a pretty safe thing to do. It's really pretty benign thing to do. So that would be an example of one of the vitamins we would use for a mitochondrial supplementation. And so sometimes I do think about, like, what are the supplements I could do to really hopefully boost energy metabolism. Maybe that gives you just a little bit of extra benefit, even though it's technically not an epilepsy treatment.
And I've been putting, for all of you too, I've been putting information in the chat. So as Dr. Gaitanis has brought up information, I've been posting attachments that you can actually go ahead and you can open up. And I will make sure at the end of today's webinar with the recording that I also send those attachments in the email to all of you as well, to make sure that everybody has them as well. We have another question by Kelly. Is it normal for a child with autism or a young adult to become nonverbal after a seizure?
Yeah, so we do see, as I mentioned, with it's not like a mild seizure that would do this, right? It's not something that you would see from, say, like an absence seizure, or even like a 2-minute generalized tonic-clonic seizure. But I do see kids who sometimes have a very prolonged seizure, like status epilepticus, who have a really significant regression for a period of time after. If it isn't that situation, if it's not like a status epilepticus, and they have loss of language, I have to consider whether the seizure itself, whether the onset was over the language center. And so that would be a different condition. But there are some kids who might have an epilepsy focus very close to language. And those same kids might have sleep activated discharges. Maybe that's affecting language. So that's also a unique circumstance that one should consider.
Another question was, does ESES put one at higher risk for SUDEP, or is it more a concern because of patient development?
So that would definitely be more on the development side. We don't know of a SUDEP risk for ESES. So, thankfully, I could say that that's not something that I think has ever been described. Many of the patients with ESES have never had a clinical seizure. A really high percentage have never had a clinical seizure. And those that do, sometimes they have really infrequent clinical seizures. But it's really only clinical seizures that seem to have that strong association. Oh, you're muted. I'm sorry.
Thank you. This next question is, my son has cortical dysplasia, anterior right temporal lobe. We are told that this is the cause of the seizures, which arrived around age 11. He was diagnosed with autism as a teen. Is it common to see both epilepsy and autism when dysplasia is seen in the MRI?
So, yeah, I think you can see both together. I think what I would think about here is, again, the sleep activated spike waves would raise some question, like, could there be sleep activated epileptic spikes that are affecting development? Could there be some subtle or subclinical seizures that are occurring more frequently than we realize too, maybe affecting development? And this is the example where I mentioned, and I'm not saying for an individual that surgery is the right answer, but sometimes when I see a child who has a focal cortical dysplasia, who also had the developmental concerns, if the seizures are really refractory and surgery is appropriate, I do sometimes see developmental improvement after surgery. Because sometimes that focal cortical dysplasia literally does nothing good. It just causes seizures and wreaks havoc on other parts of the brain that are just trying to learn. So I always have to consider that when I see the situation.
Are there any metabolic tests that you recommend that can inform treatment?
Yeah, the metabolic piece is well, actually, this kind of gets into a broader issue of like how much testing is appropriate in, say, autism. Because if you go outside of the standard medical approach, like there's a lot of interest in a whole host of different testing. Mitochondrial testing, I think, is maybe the most useful thing to think of. I do like to do for kids, any kid who had a regression, I pretty much automatically will do like some basic inborn error metabolism screening. I'll look at amino acids, organic acids, look at mitochondrial functioning, ammonia, like just try to make sure there's not a major aberration there. I think where it gets a little harder is when you start getting into things like, do I evaluate the fecal microbiome? Is that useful? Do I look at less common conditions? Like, for example, I mentioned cerebral folate deficiency, where B9 is deficient. There's other that can cause both autism and epilepsy, actually. And so I have to think about that. And sometimes I'll treat that even without doing the testing, just because the testing might be very cumbersome. If it's a safe treatment, I'm willing to entertain it. So I don't mind, making sure that, so some of the restrictive diets, it's like a good example where, is there a role for a gluten casein free diet? Is there a role for a specific carbohydrate diet or a low glycemic diet? If I think it's okay to explore those, and I think for some kids who have a lot of GI symptoms, I think there might be more benefit to doing the trial than not doing it. Do I treat with probiotics? Do I address fecal microbiome? I mean, all these things are kind of intertwined questions. They're not standard medical things, but I think in truth, if you make the child physically healthier in any way, you're going to probably help their seizures and development. So everything is intertwined, unfortunately. Sometimes poop is just as important as the seizures because these things, like just like I said, that I have kids who have Crohn's disease, and every time they have a flare up, they have a seizure. So I can't treat their seizures if I don't treat the Crohn's.
For girls with autism and epilepsy who are affected with perimenstrual, what is the likelihood that they will grow out of their epilepsy? Do they often stay treated through womanhood? And if a younger sister is suspected with autism spectrum disorder as well, is it likely she would develop epilepsy too at puberty? So it's a three-part question.
Yeah, so there's a few parts there. So, the perimenstrual issue can last really throughout much of adulthood. And so I think it's important to keep a calendar looking at the menstrual cycle and then looking at the seizures or charting behavior as well. But trying to see if this is somebody who has, if their seizures seem to have a perimenstrual quality. For people who do, it's usually about 3 to 5 days before the onset of day one of the menses, and then that risk may continue for a couple of days after onset of menses. So it's usually about a week of risk that we're dealing with. And many patients respond really well to natural progesterone therapy for this. So that can be a very effective treatment for seizures. I wouldn't discount that. And I sometimes use it in patients with autism. I have to think about that for behavior as well. Question about siblings is a pretty complex one. So the thing to know about siblings, some types of seizures have high rates of EG abnormalities in siblings, but not necessarily seizures or epilepsy in siblings. And that's where this gets complicated. So, for example, benign Rolandic epilepsy, which is the most common type of childhood epilepsy, if you check siblings, about 40% of the time, one of the siblings will have the same electrical abnormality on EG, but they may not have epilepsy or seizures ever. And then they might simply outgrow the EG change. So it would, in those cases, it would actually be a mistake to treat them because they may have never developed a seizure. They may not need a medication. And that's even true in generalized epilepsy, like absence epilepsy. Siblings have higher rates of EG abnormality, but if I think it's a tree falls in the forest kind of thing. If I don't see anything, I don't know if I want. I mean, I don't usually say I don't want to know, but I mean, I guess it's okay to know. I'm just cautious about treating if there's not an actual thing I'm treating because I worry about, overuse of medication in that situation.
I also want to say to everybody, because I didn't say this in the beginning, that Dr. Gaitanis is also on our board of directors. So we're very, very lucky to have him as well as part of EFNE helping out with the bigger picture of all of our programs and services that we do here. We're almost at the time mark at 7:59. Thank you so much for being here, Dr. Gaitanis. I so appreciate you for spending your time and being here.
Yeah, it's my pleasure. I hope it was helpful to all. If it's not, or if you had feedback, please feel free to offer that too. I'm always helpful. I'm always happy to modify things in a way that would be most useful. And so, but I appreciate the opportunity to speak. I'm happy to come back if there are topics we want to throw a little more into.
Thank you so much. I so appreciate you. Would you mind sharing your slides with me so that I
Oh,
can
of course.
share it with everybody? Awesome.
Yeah, I'll
Thank
be happy
you
to.
so
Oh,
much
sure.
for being here tonight. And I want to thank everybody for joining us tonight at our Wednesday webinar. I don't want you guys to forget that next Wednesday webinar is going to be about pediatric epilepsy surgery with a pediatric epilepsy surgeon from Boston Children's. So we're very excited to also have our next speaker up next week. So please join us next week for our next Wednesday webinar. Thank you so much, Dr. Gaitanis.
My pleasure.
For joining
Take
us.
care.
Thank you too. Everybody have a great night, and I will make sure that all of the attachments are sent. One quick house cleaning tip: if you have not put your name in the chat yet for needing a certificate for contact hours, if you're an educator or a nurse, I'm happy to send you a certificate for that contact hour for being here tonight. So please, if you can, put your name, email address in the chat so I can make sure I email you tomorrow with all of that information before we end tonight. So I'll give it a few minutes for people who have not been able to do that, to put that in the chat before we end tonight. You can save the chat. I don't know if people know this, but if you go up next to where the chat is, you hit the chat button, there's 3 dots next to it. And it said, and then you can actually hit it and say save chat. So you can actually save the chat and have it downloaded to you. But happy to send all of those brochures and all of those things for everybody. So happy to help. And yes, the contact hour can typically count for any medical license. You would just need to double check within your state. I know that Massachusetts, I did check with Massachusetts, and I do know that those contact hours do count. So just want to let you know. Maureen, you have a quick question before we end.
Yeah, how do I put my email in?
Maureen, just write in the chat box. Actually, Maureen, I have your email. I already know your email, so I'll go ahead and email. Do you need it for contact hour?
Now, what does that mean?
So if you are an educator, so a teacher or
No.
a medical professional, you can use this towards your recertification for your degree, so your practice. So like our
No,
school nurses.
no, I have the certificate.
Oh, for the
So,
training, the seizure first aid, yes, that you do have. So very happy for that. Thank you.
I mean, I do work in a school, but I'm not a teacher. I'm a lunch lady, so I'm already certified. So,
So you're all set.
yes.
Thank
So
you
I
for
don't know
that.
what did you want people for? You don't need my email.
Yep, you were all set. You were good. You were good to go, Maureen. You were all set. You're off the hook.
Thank you so much.
You're very welcome. All right,
Have
everybody,
have a great rest of your night.
yes, you too, Maureen. Everybody have a lovely night, and thank you again for being here tonight.
Thank you.
Thank you so
Have
much.
a great night, guys. Thank you.
Thank you.
Thank you.